It is pronounced as Volkmann. In Volkmann ischemic contract, F is like friend and L is silent, Man is like Monday. So it's a Volkmann ischemic contracture. It's like Volkswagen. This Volkmann ischemic contracture is the end result of an untreated ischemic episode which affects muscles and the nerve. So you are always looking at two issues, muscles and nerve. With passage of time, supple deformities become fixed if not attended, and therefore there is splinting. If you don't have, so I always ask people who practice hand surgery, where do you get your splints from? And if you don't have a backup this thing, you are not optimizing your results. A VIC can be mild, it can be moderate, it can be severe, and this is a case of not only a inappropriate incision but also poor backup of the splinting. Poor incision because there is a longitudinal scar across a transverse crease of the wrist. It is classified into mild, moderate and severe. In the mild, it is only the deeper muscles which are affected. In more moderate form, other flexors which are more superficial are affected, and a severe form, even the extensors get affected. There is nothing like a water cut. This is mild, this is moderate. In the classification, there can be further sub-classification. Non-surgical method, you are providing this splint from preventing it from getting more contractures. So maintain a range of motion of muscles which are affected or not affected, and strengthen rest of the muscles. You strengthen the rest of the muscles. How long you wait? You wait for 3 months to 6 months. This is debated. Why you wait? The marginal muscles which are neither dead nor alive, they probably can regenerate, and you need this much of time period. In a milder form, the FDP and FPL, which are very close to the radius ulna and which are the deepest muscle, they are the ones which are affected. Then what do? You splint them. You use one of these splint. You can not only flex your finger, but you can transfer it to your thumb. You can transfer it to thumb. So you pull only the thumb part only. So you mobilize all the joints which are affected, prevent the first wave contracture. There are times when practically patient will require all the splints. Sometimes for wrist, sometimes for fingers, sometimes for MP joint, sometimes for web, and sometimes keep modifying depending on the joint which you notice is getting affected. Why splints? The patient can go to the therapist once, twice, 3 times a day. But once the splints are there, the dynamic splints are there, they are utilizing the stretching capabilities of the splinting practically all their waking hours, and if they're keeping during the sleep, even those times. How often we see the patient says in the morning it doesn't move, it's very stiff. We are not talking about rheumatological condition. It is stiff because the patient has rested for 8 hours and the muscles have not moved for those 8 hours. And therefore, these splints can even be used within the tolerance of the patient during their sleeping hours also. Various options have been given for restoring the length. Shortening has been said to be no. Proximal row corpectomy has been said to be no. So what are the treatment options? The two options that the multiple options described. The one that I have often used is the flexor muscle slide and tendon transfer, or a combination of these two. How do you plan to see after once the patient is ready, rehabilitation has been done, the waiting period is over, what is available and what is lost? Because what is available is going to be the source for what is to be provided for. So who's going to pay for the people who require free treatment? The people who are sitting in the hall. So tabulate the source of income, and the government is going to give that money to people who don't want to work. So tabulate what is available. What is available is whether profundus is working, whether sublimus is working, if not, whether the extensors are working, if not, free functioning muscle transfer is to be done microsurgically. So we have this patient with FPL affected, FDP affected, but in early cases the nerves are not affected. So what you do? Muscle slide. You know this ulna, you have a subcutaneous border, so very easy dissection. You go along the subcutaneous border of the ulna and slide along the subcutaneous and come to the deeper surface and keep going entry surface of the interosseous muscle and come on this side. And so you have a subcutaneous border and you dissect out the subcutaneous border and you free up the FDP muscle and you can erase very easily because you have started on the subcutaneous border and therefore it was easy. And as you come on the anterior surface of the ulna, you come to the red part, the profundus muscle, and you can erase the whole profundus and go right to the opposite side and free up the FPL muscle also. So in moderate type, it is not only the muscle, it is the nerve also which is involved, and therefore you have to in addition do a neurolysis of the two affected muscle. This would give you some result, this may not give you result. If this gives you result, the matter is over. If that does not give you result, then the patient requires a second surgery, that is a tendon transfer from whatever is available. So let's have the first example: fracture radius ulna, scar, tight plaster, compartment syndrome, missed, VIC, clawing. In Volkmann's sign, if you flex the wrist, the fingers can be stretched. But if you extend the wrist, if you flex the wrist, the fingers can be extended. But with the wrist extended, you can't. So this is Volkmann's sign. Whereas in the compartment syndrome, the wrist is not moved. It is just stretching, irrespective of the position of the wrist. Make an incision on the medial side and you dissect out everything that is in front, on the side and front of the ulna, going across the interosseous membrane, going on to the radius. And you'll see, sure enough, this is your medial epicondyle, this is your ulnar nerve, and you'll see the ulnar nerve. Can you appreciate the compression of the ulnar nerve here? So you see the compressed nerve and this is decompressed. Now, very important thing. You have identified your median nerve, you have identified the ulnar nerve. Having identified everything that is away from these two, that is originating from the medial epicondyle, is cut. So you have cut the flexor pronator origin from the medial epicondyle. And now you have the whole ulna which is bare on the medial side in front, and profundus is free, and across FPL and what they can free that also. The recovery is incomplete like this patient. So we took one of the tendons, ECRB, and this was the range of motion. ECRB was transferred anteriorly en masse to the profundus, and en masse suturing was done, and this is the preoperative flexion, and this is a postoperative flexion after tendon transfer. So there may be patients who do not respond to muscle slide, but one good thing is at least the sensation comes back. So sensation comes back, very important, and then you can do a tendon transfer. In summary, make an inventory of what is needed, what muscles are not working, and what is available, and then you compute what is available to what is required, do an appropriate matching, and you can have a reasonable function. So in mild situation, nerves are not affected, you stretch them, you slide them, and if not working, you do a tendon transfer. In moderate situation, in addition, you will require a nerve treatment. In severe situation, when none is available, you require microsurgery, so do a muscle transfer.